In stage 3 disease, we're very much interested in long-term outcomes. What I mean by that is the survival endpoints, whether it be progression-free survival or overall survival at the longer time points of 3, 4, and 5 years. The updated PFS curve with continued separation and pretty much the same numbers that we saw with the initial PFS curve suggest that the impact of that year of checkpoint inhibition is durable, that we really are curing the patients we think that we're curing. And this continued separation of those curves really reinforces that concept. In terms of safety from the Pacific trial, I must say there were many of us who were potentially concerned about using a checkpoint inhibitor after chemoradiation. The most important concern that we had, I think, was with regard to the rate of lung toxicity. Obviously, pneumonitis is a common problem as a result of radiation, and we know that checkpoint inhibitors have a low rate of pneumonitis associated with them. And so the question from the Pacific trial was, were you going to see a increased risk of pneumonitis given two modalities that do cause pneumonitis? And just focusing on pneumonitis, to start with, I think reassuredly we saw that there was a little bit more pneumonitis on the Durvalumab arm, but it was mostly grade 1 or 2. That if you look specifically at grade 3 or 4, which is severe or life-threatening toxicity, the overall rates on both arms, Durvalumab and placebo, was about 3%. So there didn't appear to be any difference between the two arms with regard to severe or life-threatening grade 3 or 4 toxicity. So that was very reassuring. If you step back and look at all the other toxicities, I think to summarize it in a way that's important to clinicians is that there were no surprises with regard to the side effects of checkpoint inhibition. We saw the typical things, the immune-related side effects that you would typically see. I think all oncologists are used to giving checkpoint inhibitors in the stage 4 setting. There was really nothing new in the stage 3 setting from what we knew from stage 4. The typical itises that we would occur, dermatitis, hepatitis, colitis, these sorts of things were pretty much as expected. The one concern, again, as I mentioned, was there going to be an increased risk of pneumonitis? And as I mentioned, slightly higher rate overall of pneumonitis, but in terms of severe life-threatening grade 3 or 4, really no difference in relatively low rates of about 3%. So that was very reassuring with regard to the safety from the Pacific trial. I think there's no doubt in my mind that the results of the Pacific trial really bring us to a new standard of care in stage 3 disease, and that the potential benefit in long-term survival and overall cure rates is so significant that the risks are really quite minimal, in my opinion, with regard to that, thinking about the risk-benefit sort of thing. I think the investment from the patient's perspective of committing to a year of therapy is not insignificant, but that investment does translate into a 32% reduction in the risk of death. That is very significant. Most patients with stage 3 non-small cell lung cancer with a good performance status, their goal is to be cured. And when you say to them that they have a slightly greater than 30% reduction in the risk of death, that is significant to patients. And certainly the risk that we put them at with regard to use of checkpoint inhibition, I think is minimal relative to that 30%, 30+% reduction in the risk of death.